So the diagnosis was triple negative breast cancer. That's what the pathology came back as. Within a period of about 8 days, I got a second opinion from the Vassar Center, which specializes in BRCA. I found a new surgical team at an entirely different institution. I went to see Dr. Elisa at the Dubin Center at Mount Sinai. She came highly recommended. The surgery was very successful.
What we found is that your main tumor that had formed was 1.8 centimeters, and we did check lymph nodes also for spread, and I removed a few lymph nodes that were all normal. That was great news. What's really interesting is that with triple negative breast cancer, believe it or not, even though it is more aggressive, and we typically associate lymph node spread with more aggressive, you don't see a lot of lymph node spread as much with triple negatives, and so that can be a tricky thing. So the fact that your lymph nodes were normal was very in line with what I would have expected, certainly good news.
Do you consider my cancer to be a stage 1?
You know, staging of breast cancer, first of all, there's no one size fits all. And what I would say, Stacey, is that the staging of breast cancer has really evolved over time. By the old definition of staging, any tumor smaller than 2 centimeters with negative nodes is a stage 1. The problem is that doesn't take into account the nuance in the different types of cancers, right? In the new version of staging, triple negative is not usually considered stage 1. Breast cancer, as I say, is not just one disease, okay? There are different subtypes. And we have the luxury of treating in a very individualized, personalized, tailored way based on the subtype of cancer that someone has. When someone has a biopsy, and that biopsy shows cancer, they then run 3 tests on that cancer to tell us what might be feeding it, making it grow, making it tick. Okay? And the 3 tests they do are called estrogen receptor. Most people know estrogen is a hormone. So this is telling us if estrogen, the hormone, is feeding the cancer. Progesterone receptor, also a hormone. If that's positive, progesterone is feeding the cancer. And together those two tell us if hormones are feeding the cancer. The third test, which is less commonly known, is called HER2/neu. HER2/neu is when that's what's called amplified. It's a HER2/neu positive cancer, which is present in about 20% of all breast cancers. That's, believe it or not, treated as kind of its own tumor type. So one subtype of breast cancer is called HER2/neu positive breast cancer.
And so if you're triple negative,
if you are triple negative, that means your tumor is A, not being fed by estrogen. That's one of the triple. B, not being fed by progesterone. And C, not HER2 positive. So it's negative for all those things. Now, the reason why that's considered a more aggressive kind of cancer and why it's a little bit more concerning is because what's been developed over the last 20 years is very targeted therapies for estrogen receptor, progesterone receptor, and HER2/neu. If we know that hormones are feeding a cancer, Stacey, we have these hormone blockers. And so what I always tell patients, it's like, imagine your cancer is a plant and estrogen is the water. Just stop watering the plant and it's going to wither and die. So anti-hormonal therapy is super effective in preventing estrogen positive cancers from coming back. But guess what? If estrogen is not feeding the cancer to begin with, blocking that estrogen has 0 effect.
There's no targeted therapies.
There's no targeted therapy. Exactly your point. What does work, though, is chemotherapy. So chemotherapy is very effective in most triple negative breast cancer. And we see people with excellent responses with old school chemo, with newer chemo. There are medications, as you know now, that have been developed specifically for BRCA positive patients. And so we do have a lot more options than ever before even in our triple negative breast cancer patients. And I would say they are curable, they are treatable, they are not a death sentence. And we go, full court press to cure triple negative breast cancers. It's just a different pathway to get there.
Does it seem crazy for a 20-year-old or 30-year-old going in for this procedure to say, please take all the tissue as much as possible?
I mean, listen, I don't think anything's crazy to say. I think, sadly, it should go without saying that that is the shared goal. I do think that there are some times where patients also have other goals, which is, a more natural look. Well, a more natural look could be code for leaving more tissue behind. What I always say is, this is not a breast augmentation. It's not, forgive the expression, it's not a boob job. And we always have to keep our eye on the prize of making sure we keep our goals aligned with giving someone the lowest possible chance of getting breast cancer. That has to be the shared goal.
The thing is, once you have a mastectomy, you have much less breast tissue and you can really feel things. And it is important to get to know your new breasts. And I think that's a very, very good message.
Physical examination is supposed to be the most reliable way to pick something up.
So if you're a young woman and you're 10 years out from your mastectomy, and suddenly it would be the most likely place to feel something.
Correct.
It would be right under the skin.
Correct. And women say to themselves, I don't examine myself, I don't. They do. Guess what? Okay. When you take a shower and you wash yourself, in general, you run your fingers over the surface of your skin. And, we worry about sometimes breast tissue under the armpit. Well, guess what? I mean, that's where most people wash pretty thoroughly. Those are the ways. I try to make it not be stigmatized and not be a big deal, but these are ways that people inadvertently examine themselves. Be familiar as a woman, as a man, with what's normal for you. We would never tell someone, for example, don't look at the moles on your skin and advocate for yourself in that way. We would never do that. But because it's been stigmatized that women are, let's talk about women who don't get mastectomies and who don't have BRCA. Don't examine yourself. You're going to feel all kinds of things. You're going to get crazy. How is that appropriate in any way? Just be familiar with what's normal for you.